All right, welcome. Think of this as your hot seat for a consultant-level Viva exam. This isn't just about what you know, it's about applying a rock-solid, systematic approach when the pressure's on. You're the candidate, I'm the examiner, let's get into it.
Okay, here's the structure for today. We'll start with the case, run through the primary survey, talk resuscitation, hit the secondary survey, then I'll throw you a curveball with a special case, and we'll wrap up with a debrief. Let's get started.
Right, let's set the scene. You are the trauma team leader. The paramedics are calling in, they're on their way with a patient from a bad car crash. This is what they tell you.
And he's here. The patient is rolled in, he's agitated, he's in rough shape. The team is looking at you, you're in charge. So tell me, what's your very first move? Where do you even begin?
Okay, if you said primary survey, you're absolutely right. That's the bedrock of trauma care. The rule is simple, but it's everything. You find and you fix the life-threatening problems, step by step, before moving on. So let's start with A.
So he's right there in front of you. You can see he's breathing fast, he's agitated. Talk me through it. A, for airway. What are you looking for, and what's the one thing you absolutely must do, no exceptions?
Excellent. You're thinking along the right lines. You know, a classic quick and dirty assessment is just asking their name. If they can answer clearly, their airway is patent, at least for that moment. But you're right. The most critical point, the one you can't ever forget, is the C-spine. Every trauma patient has a C-spine injury until you prove otherwise. Immobilization is totally non-negotiable.
Okay, so he's talking, which is great. Airway's patent for now, but he's clearly struggling to get words out, so we can't get comfortable. Let's move straight on to B for breathing.
Right, the airway's taken care of for the moment. Now let's focus on the mechanics of breathing and ventilation. Be systematic. Tell me exactly what physical exam findings you're looking for.
Perfect. It's that classic look, listen, and feel approach, isn't it? You're seeing the high respiratory rate, the accessory muscles firing, you're checking for tracheal deviation, and once the chest is exposed, you're looking hard for any asymmetry, you're listening for air entry, and you're percussing. Each one of those steps is giving you a vital piece of the puzzle.
And bingo, there it is. A whole cluster of red flags. The right side of his chest isn't moving right, you hear nothing with the stethoscope, and it's dull when you percuss. You've just nailed the diagnosis of a massive hemothorax. Now, in the real world, you'd be grabbing a chest tube right now, but for the viva, let's finish the survey. On to C.
Good. C for circulation. And his vitals, they're not good. Heart rate's flying at 128, BP is in the toilet at 90/52. This is shock. So based on these numbers, what ATLS class of hemorrhagic shock are we talking about?
Yeah, and this table is our roadmap, isn't it? With a heart rate over 120 and that dropping blood pressure, he's firmly in class 3 shock. And what does that really mean? It means he's probably lost up to 40% of his entire blood volume. That fact changes everything about how we're going to treat him.
Okay, you smartly grab the ultrasound probe for a quick EFAST scan. It's just an extension of your hands at this point, and yep, it confirms what you thought. You see the fluid in the right chest. But wait, you also see fluid around the heart. This just got way more complicated. Now you're dealing with two killers at once, hemorrhagic shock and obstructive shock from tamponade.
Okay, moving on. D for disability. The tool here is, of course, the Glasgow Coma Scale. And what's the magic number we all have to remember? It's 8. A GCS of 8 or less means you're thinking intubate, because they likely can't protect their own airway anymore.
Good news, his GCS is 15, so he's with us, even if he's agitated. For E, exposure, you've gotten him fully undressed, keeping him warm, and you spot that classic seatbelt sign across his chest. So, the primary survey is done, you've found multiple immediate life threats. Now what do you do?
Right, this is the moment. This is where you actually save his life. You've identified the problems, now you've got to act, and act fast. This part is all about those immediate, life-saving interventions that you're doing in parallel with your survey.
Okay, here's the game plan. First access, 2 big IVs, nothing smaller. We'll start fluids, but you're immediately shouting to activate the massive transfusion protocol. We need blood products now. You're also giving tranexamic acid, a critical move. And based on that EFAST scan, your team is preparing for 2 procedures at once, a large bore chest tube for that hemothorax, and you're getting ready for a pericardiocentesis or maybe even a thoracotomy for that tamponade. Okay, resuscitation is happening, your team is moving, things are getting under control. Now you can take half a step back and start the secondary survey. This is your systematic head-to-toe examination to make absolutely sure you haven't missed anything.
And our guide for the history is the good old SAMPLE mnemonic. We're digging for clues here. And M for medications is huge. What if this guy's on blood thinners? With a class 3 bleed? That's a total game changer. And of course, L for last oral intake. The anesthesiologist is definitely going to want to know that.
All right, you've handled that case very well. Your patient is stabilizing. But any good consultant knows how to pivot. So let's throw a wrench in the works. A little viva twist to test your adaptability.
Okay, good. Now let's reset. Wipe that last case from your mind. A new ambulance pulls up. Same story, high-speed MVA. But this time, it's a 28-year-old female, and she's very obviously pregnant, about 32 weeks along. Suddenly, you've got 2 patients to worry about. How does your management change? Go.
This is a classic high-yield scenario. First thing you do, get her off her back. Manually displace that uterus to the left to get it off the vena cava. That's step 1. Second, you have to remember her physiology is completely different. She can bleed a ton before her own vitals crash, but the fetus will be in distress long before that. So continuous fetal monitoring is a must. And here's the big pitfall, the thing people get wrong. You always treat the mother first. The best resuscitation for the fetus is a perfect resuscitation of the mother, period.
Here's another way we test if you're current with your knowledge. Let's switch gears to a pediatric patient. The old ATLS guideline, you might remember, was to give 2 fluid boluses. Not anymore. The new guideline is key, 120 cc per kilo bolus of crystalloid, and if they're still unstable, you go straight to blood at 10 cc per kilo. And the reason why is so important, we want to avoid that crystalloid overload and get them oxygen-carrying capacity way sooner. All right, we're wrapping up the Viva now. Let's have a quick debrief. The whole point of an exam like this is to see if you have a safe, repeatable, and adaptable system for when things go really wrong.
So, what are the big takeaways here? First, that ABCDE approach. It's your safety net. It works every time. Second, recognizing and classifying shock early is absolutely critical. Third, don't mess around. Stop the bleeding. And of course, you have to know how to tweak your approach for special patients, like kids or pregnant women. Finally, never forget that secondary survey. It's how you find the injuries that can kill a patient a day later.
You've done an excellent job in the trauma bay. The patient's stabilized and on their way to the OR. But your job isn't done. And that brings me to my final question for you today. What are you looking for in the next 24 hours? What is the point of that tertiary survey? Because the care of a trauma patient never really ends in the emergency department. Think about that. You did well today.